All right, so role of transplant in mantle cell is very limited in first-line
Shaky.
settings.
Yeah.
That is because our treatments are getting better, particularly now we're using BTK inhibitors here, which takes us to ENRICH study. Pallawi, what did the study show? And based on its findings, if this was to get approved in first-line settings, what is going to be your treatment paradigm?
Yeah, so this was one of the studies where I haven't made up my mind, to be honest. It's because the devil is in the details. Patients could get chemoimmunotherapy or ibrutinib and rituximab. But the problem is all chemoimmunotherapy is not the same. The study was done primarily in Europe, where their standard of care is still R-CHOP. In the US, at least in my practice, and I know most practices, we tend to use rituximab and bendamustine for our patients. So there was a smaller subset of patients who got rituximab bendamustine. Overall, ibrutinib rituximab was really much better than chemoimmunotherapy, but the benefit was being driven by patients who got R-CHOP. So yes, if your options are R-CHOP versus ibrutinib rituximab, absolutely you should go for ibrutinib rituximab. But if choices is between rituximab bendamustine or ibrutinib rituximab, then it gets a little bit trickier. Also, chemo is only 6 months, even with rituximab bendamustine. And on the other arm, you continue ibrutinib till disease progression, which would have been your second line treatment anyway if patients had disease progression after rituximab bendamustine. So, and of course, there's no overall survival benefit from what I remember. So then are you really, is it just the effect of that first line therapy, or is it because you're combining first and second line therapy, is what I'm thinking. To give ibrutinib rituximab credit, most patients it's much better tolerated. And as we did in the triangle study, we are going to substitute ibrutinib with a second generation BTK inhibitor. If a patient is above 80 and they look really frail and I feel like they're not going to pass muster for chemotherapy, at least if this gets approved, I have a great option to present to them, which works equivalent or even better with a better side effect profile. But when I present, I probably have to present both to my patients. You have 6 months worth of treatment or continuous treatment. What do you pick, kind of thing?
I think just like CLL, it's always a debate whether time-limited treatment versus lifetime. Having better BTK inhibitors, we will be relying on zanubrutinib or acalabrutinib. While you're talking on that debate of zanu versus acal, any particular preference you have between the two?
So, I mean, I'll tell you my preference, but I really don't have a good reason. I have probably exclusively used zanubrutinib. Initially, it was because there was randomized data in CLL that zanubrutinib was better than ibrutinib. Not to say Acala is not, but then I started using Xanu more, and now I have this comfort level. Also, Xanu, you can give 320 milligram once a day
Right.
versus Acala is 100 twice a day. So I feel like for patients, it's a little bit easier to remember that.
Pallavi, coming back to the same idea of BR versus BTK inhibitors or Rituxan, if you are going to use BR, any role of adding BTK inhibitors and then continuing with BTK inhibitors in that settings?
So that's a very good question. And there are two studies that we have to think about when we try to answer that question. The first is the SHINE study, which was combining ibrutinib with BR. And that was really a no-go because there was a progression-free survival benefit, but there were so many increased toxicities that led to withdrawal of ibrutinib from the market for mantle cell lymphoma in the US. But then this was followed by the ECHO study, where they used the same idea, but they combined acalabrutinib with BR. That study showed that the side effects were manageable, not too increased. But also in that study, acalabrutinib was continued to progression. And there was a PFS benefit where it was similar to what you would get if you used acala in the second line setting. By combining it in the front line setting, you're not getting too much extra out of it. It depends on how a person looks at it. You could use all of them up front and then you're not worried about progression, or you could say, well, these are older patients. You may not have disease progression, so you may never need it. So why not just save it for later? I'm more in the conservative camp. I'd like to use one thing at a time unless I can really make them live longer or improve their quality of life.
Well, it has certainly been an exciting ASH. What we have learned is that there are management techniques that we can utilize by de-escalating. That is, not doing more is always the right thing. Thank you, Dr. Torka, for walking us through these studies. For our listeners, let us go over a quick recap. Pallavi, Rahul, we have covered San Antonio Breast Cancer Symposium and ASH 2024. one common thread has been how fast things are changing in every disease site. And in community settings, we get to see all this and enjoy all these successes.
Rohit, you're right, but all this data coming at us can also be overwhelming. Just
Indeed.
today in our discussion with Dr. Pallavi Torka from Memorial Sloan Kettering, we've discussed 4 studies, and each one of these studies is important. Based off Polarex, polatuzumab is approved in first-line settings, and PFS is impressive. But we did not see clear overall survival in all comers. Then, for InMind study, tafasitamab looks promising in refractory settings for follicular lymphoma. In mantle cell lymphoma, role of transplant upfront is bleak, and Triangle study reiterated this. And then lastly, we've covered ENRICH study, where BTK inhibitors in front line with rituximab seems to be very appealing.
Rahul, let's not forget about the key side effects in management of tafasitamab, as we will likely see more and more use of this drug in community settings. In our TalksCheck discussions, we will focus more on these adverse events and their management. Thanks for joining us as we finish our ASH 2024 conference highlights.